Phase 1 biotransformation involves the complex enzymes of the cytochrome P450 system. In reality, the cytochrome P450 system set of enzymes are highly inducible, or they can be inhibited. There are 17 families, about 39 subfamilies, and genetic polymorphisms do exist. Basically, the drugs may be metabolized by a particular cytochrome P450 system or a whole group of the cytochrome P450 systems. It is important to understand that significant drug interactions happen within the cytochrome P450 system. Inhibition of the cytochrome P450 system may inhibit concurrently administered drugs and therefore cause toxicity. On the other hand, inducers of the cytochrome P450 system may increase the metabolism of concurrently administered drugs and therefore reduce clinical failure. There are a very complex set of enzymes. However, cytochrome P450 3A4 is the most significant one that metabolizes up to 70% of drugs in the physician drug reference. The other important ones are 2D6 and 1A2. It is crucial for us to understand the important high-yield interactions that happens with cytochrome P450 system. Therefore, we need to understand what are the major inhibitors and what are the major inducers. Let's look at the inhibitors first. Examples: grapefruit juice, cimetidine, omeprazole, all your macrolide antibiotics, azole antifungals, and acute alcohol. As an example, cimetidine specifically inhibits 2C9. If diazepam, the benzodiazepine, is given concurrently, you will inhibit the metabolism of diazepam and cause accumulation of diazepam in the plasma and therefore cause diazepam toxicity. Grapefruit juice particularly has a very important interaction with statins. It inhibits the metabolism of statins and if given concurrently can actually cause rhabdomyolysis and renal failure. Inducers are those that increase the metabolism of concurrently administered drugs by increasing the activity of the cytochrome P450 system. Barbiturates, all your anticonvulsants except valproate, rifampin, and chronic alcohol are potent inducers. Rifampin, for example, by inducing 3A4, will cause increased metabolism of oral contraceptives, subsequently causing oral contraceptive failure. Chronic alcoholics should never be given acetaminophen. It will increase the metabolism of acetaminophen, and while the toxic metabolite is only 5% of the total metabolites, it will accumulate and these patients can go into fulminant hepatic. Phase 2 biotransformation is different in the sense that the phase 2 biotransformation basically encompasses the drug and makes it water soluble. The important reactions here is glucuronidation, sulfate conjugation, amino acid conjugation, and glutathione conjugation. The two important ones are glutathione conjugation and glucuronidation. Essentially, it inactivates the drug, makes it water soluble, so it can be very readily excreted. As usual, there are a couple of exceptions. Morphine, your opioid analgesic, is the only drug that is activated by phase 2 biotransformation. It actually forms two metabolites, 6-beta-glucuronide and 3-beta-glucuronide, both of which have analgesic potency. Chloramphenicol should never be given to neonates. Neonates do not have any ability to undergo glucuronidation until they reach about 2 to 3 years of age. The important interaction here is that if chloramphenicol is given to a neonate, because they cannot undergo glucuronidation, they will present with the gray baby syndrome, which can be fatal. Essentially, they become pale and cyanosed, they have abdominal distension, nausea and vomiting, they fail to eat and thrive, and will ultimately die of respiratory and vasomotor collapse. Acetaminophen undergoes glutathione conjugation and also sulfation, and methyl dopa also undergoes sulfation. The other important high-yield information, and the important information here, is that some patients may be slow acetylators. And in slow acetylators, they will present with the butterfly rash or the SLE syndrome. And the most important drugs involved here: hydralazine, isoniazid, and procainamide. It should be procainamide and not pyrazinamide. So this is just for information as to all the phase 2 reactions that happen, but basically glucuronidation and glutathione conjugation and acetylation are most important. There are different sets of metabolizers, and they fall under four different categories: ultra rapid, extensive, intermediate, and poor. Those that are ultra rapid may undergo treatment failure because they metabolize too fast, and those that are poor metabolizers basically will have a very high risk for side effects. As I said, you have polymorphic issues, genetic polymorphisms, which may affect the dose of the drug or have adverse drug reactions and toxicity, and also exacerbated drug-drug interactions and possibility of pro-drug activation. As an example, look at the CYP2D6 phenotypes. Caucasians, African Americans, and Asians are poor metabolizers, where Scandinavians, Spanish, and Ethiopians are considered to be ultra-rapid metabolizers. So at a low dose of a drug, metabolism is always first order, equal to the dose of the drug, and if you saturate it at high doses, it becomes zero order, which is constant and independent of the drug dose. And finally, drug excretion. Drug excretion is dependent on three very important steps: filtration, secretion, and reabsorption. And if you recall the renal physiology, normal glomerular filtration rate is 120 mL per minute, and all the drugs will enter the filtrate. If it's bound to plasma proteins, it will not go anywhere. In the proximal part of the renal tubule, secretion happens, and also active reabsorption. Anything that remains lipid soluble will be reabsorbed. Anything that remains water soluble will be excreted into the urine. As a result, the net renal excretion is equal to the amount of drug filtered at the glomerulus, plus whatever active secretion may happen via the anionic and the cationic co-transporters in the proximal tubule, minus whatever lipid-soluble drug will be passively reabsorbed through the tubule. Therefore, rate of elimination is equal to glomerular filtration rate plus active secretion minus the reabsorption. And clearance is defined as the volume of blood cleared of the drug per unit time. Clearance is always equal directly to the glomerular filtration rate when there is no reabsorption or secretion and no plasma protein binding. The protein-bound drug is never cleared, therefore clearance is always dependent on the free fraction or the unbound fraction of the drug multiplied by filtration rate. First order elimination rate always indicates a constant amount of the drug being eliminated per unit time, and 99% of drugs follow first order elimination rates, and is dependent on the half-life of a drug, which means that every half-life you lose half of the drug. In this example, we're starting with 80 milligrams. The drug has a half-life of 4 hours, so every 4 hours you lose half of the drug, and at the end of 16 hours you will have only 5 grams remaining. Zero order elimination is very limited. It applies mostly to phenytoin and toxic levels of salicylates. This is defined as a constant amount of the drug being eliminated per unit time and does not depend on half-life. In this example, you're starting with 80 milligrams again, but you're only eliminating 10 milligrams per 4 hours. So in this example of zero order elimination, at the end of 16 hours you are left with 40 milligrams, because you're only losing 10 milligrams per hour, and it is not dependent on half-life. So in a nutshell, your free drug enters the glomerulus depending on glomerular filtration rate, goes down the proximal tubule, and then whatever remains lipid soluble will undergo passive reabsorption, and whatever remains ionized, lipid insoluble, will ultimately be excreted. At the end of the day, drug excretion or drug elimination is not the same thing. The effects of a drug may be eliminated via metabolism, which means inactive metabolites may persist in plasma until it is ultimately excreted in the kidneys. Ionization and non-ionization again applies to drug excretion. drug excretion, and in situations of overdoses and toxicity, we apply these principles to enhance the excretion of a drug. Acidifying urine will increase ionization of weak bases, for example quinidine. And if you acidify the urine, you'll increase renal excretion. Conversely, if you make the urine more alkaline, you will increase the ionization of weak acids and therefore increase the renal excretion of weak acids, for example, in a situation of aspirin overdose. Ammonium chloride, cranberry juice, and vitamin C will acidify urine, and sodium bicarbonate and acetazolamide, which is your carbonic anhydrase diuretic, will make the urine much alkaline. The loading dose, which you will be dealing with quite often, basically means trying to reach a high concentration and trying to start steady state concentrations. The formula for loading dose is volume of distribution times the concentration on plasma divided by F, which is the bioavailability. If it is given intravenously, naturally, your bioavailability will be 100% and therefore F will be equal to 1. So this is showing you using a loading dose to get to steady state concentrations faster. The green line shows giving a quick loading dose and you achieve the effective or go above the effective concentrations, and then you maintain steady state. Conversely, the red dots are showing achieving steady state with repeated dosing of the drug, and this will take quite a bit of time. Once you give the loading dose, you need to maintain that dose in your patients with a maintenance dose, and the formula for maintenance dose is clearance times concentration in plasma divided by bioavailability. Note that maintenance dose takes into account clearance, which means in patients who have renal dysfunction, you will have to adjust for the clearance levels and the renal function. At the end of the day, it's all about the lipid bilayer membrane, which determines drug transport. And all of these three factors act in harmony, and as I said in the beginning, it reaches a dynamic equilibrium between absorption, distribution, metabolism, and elimination. That equilibrium is essential in determining the final concentration of the drug at the receptor site and ultimately its clinical